Okay, so for the next 10 minutes, I will be going through what constitutes good clinical practice with respect to long-term opioid prescribing. And I'd just like to start really to start getting us thinking about why we are discussing this topic, why have we given so much focus to this topic, and I just invite the audience to just reflect on that in their own clinical and non-clinical practice. These are my disclosures. So what does good practice look like? For the next 5 to 10 minutes, we'll be outlining and defining the scope of the opioid crisis in the US, but also what I would describe as the emergent opioid crisis in the UK. We'll look at the association between prescribed opioid analgesia and opioid-related death. We're going to describe some of the challenges we face in primary care when managing patients with long-term opioid use, and highlight some of the patient intersectional factors which impact opioid prescribing. And then we're going to bring all of that together and map what I feel are the key components of good clinical practice. So prescribed opioid medications are potent acute analgesics, and they've been used historically for relief of acute pain. And they're associated with significant side effects and a risk profile, but it's their features of tolerance and dependence in particular which is problematic. Tolerance describes increments in dose to achieve the same therapeutic effect, and dependency, the propensity to develop significant unwanted physical symptoms on withdrawal of medication. They're CNS acting with psychoactive properties, and they potentiate the reward pathways that are linked to addictive behaviors. And it's these characteristics and features which makes their long-term use particularly problematic. So what did we learn from the opioid crisis in the US? Across 2 decades, there was more than 600,000 deaths. And the public health research into the crisis in the US identified 3 distinct phases in time. The first was linked to the increased prescribed opioids in community and hospital settings. The second phase was higher doses and escalating use of prescribed opiates. And the third phase was misuse, first on access from street misuse and then synthetic opioids. And this article from the British Journal of Pain really discusses the problems in the UK. We are amongst the highest prescribers for opioid-based medication in the UK, and maybe it's the strength of our NHS structure. Thankfully, our mortality is significantly lower than our colleagues in the US, but that shouldn't give us room for complacency. In chronic pain, we're aware of national guidelines which advocate against long-term opioid use. But the problem is 47% of patients with chronic pain still receive long-term opioid prescribed medication. You'll be familiar with this public health report published in 2019. They looked at dependence and withdrawal forming medication that are prescribed, and they found in 2017, 13% of the UK population had either received or been dispensed a prescribed opiate medication. And in the coming years, over the next 4 years, there was a fall in prescribing rates, some 450,000 reduction in 450,000 prescriptions for opioid-based medication. So that's encouraging news. But what's concerning is the mortality continues to rise. These are concerning trends. In fact, since 1993, the poisoning rate secondary to opioid poisoning has increased every year. And opioid-related poisoning has been increasing since 2012 and continues to be the case. Last year, 5,500 people died from opioid-based poisoning. So the question may be asked, why is the death rate and the poisoning rate increasing when our prescription rates are reducing? Is this simply reflective of recreational substance misuse and more of a social societal problem, or is there an iatrogenic factor? The concerning thing is the public health research, and there's a significant body of public health research, is showing there is an association between prescribed opioid use and subsequent misuse. And there's three basic ideas that are postulated. One is prescribed opioids are gateways to misuse. Substance misusers commonly cite prescribed opiates as the first gateway to a whole host of substances they go on to misuse. So it becomes a bridge to other substances of misuse. We'll speak a little bit about opioid use disorder as we move through the presentation, but there are issues around dependence and addiction. And then lastly, the transition from prescribed opioid use to illicit substances is particularly problematic. And more recently, you'll be aware of the availability of synthetic, super potent opioids people are purchasing from the internet and illegal sources, which are particularly potent, problematic, and lethal. So we're familiar with this, what I would call staircase of dependence. We're also familiar with the WHO prescribing for acute analgesia, but I like this staircase of dependence. In primary care, we see patients with acute pain, and often we have limited options and may be forced to prescribe an acute opioid-based prescription. It finds its way re-prescribed, and within weeks, tolerance and dependency can ensue. Meanwhile, the acute pain develops a chronicity in and around months, 3 months or so. And then the increased opioid use, despite any significant change in the pain profile or function, is particularly concerning. And then further on, a deteriorating function with addiction behaviors can be particularly problematic. So you see this staircase of opioid dependence. So what is the challenge in primary care? I would identify 5 areas. The first would be reducing acute prescriptions for opioid-based medication. We need to look at that. The second thing is tackling this opioid staircase of dependence. Is there a way we can stop patients moving up the staircase and the other way around, actually supporting patients to come down from that staircase? Raising awareness of the risks of alternate sourcing, patients Googling and identifying substances, opiate-based substances from the internet, educating them the risks of that. Clinician challenges, both in the consultation, confrontation, adverse outcomes, managing withdrawal, and then also from a service perspective, access to specialist services. It's very time-consuming. It can be potentially risky. The patient challenges and fears. Opioids sometimes used as a crutch for patients in the absence of any meaningful pain support. Fear, stigma, and the actual population profile of people who are overusing these medications are all things that we need to address. And this is from a paper which showed the intersectional factors impacting long-term opioid use. We know that patients from the least deprived areas are 53% more likely to have a long-term opioid prescribed compared to the least deprived areas. And there's this whole raft of intersectional factors. And as clinicians, we may have little impact when it comes to the most political and societal factors. But when it comes to the clinical areas in particular, we can make a meaningful difference. And I've put up this slide because it's those same intersectional factors, for example, childhood ACEs, access to good social care and support, which is also the overall demographic of our patients who are overwhelmingly suffering from chronic pain and also long-term conditions in the context of significant health inequalities. So what might good practice look like? We need to have a MDT approach. There has to be consistent messaging from primary and secondary care. The community pain support services need investment, they need support, they need to be accessible and well funded. We need substance misuse services which ideally can accept patients who have developed prescribed opioid dependence. We need to have consistent messaging and language. That's critical. We need to look at our prescribing behaviours, access, as we've discussed, proactively screening and identifying patients, who's at high risk, who could we potentially work with, supporting all patients with chronic pain. Irrespective of our prescribing, we need to be making sure we're providing that holistic support. And then lastly, a pragmatic approach. How do we go about doing this? We're all busy, we work in generally under-resourced settings. How can we work with what we have to make a meaningful difference?